Good evening, everybody, and welcome to this evening's webinar, Goals of Care in the COVID-19 Environment. Before I hand you over to your presenters, just a couple of small housekeeping notes. Everybody has been placed on mute to minimise background noise, but we would still love to hear from you. So you should be able to see a dashboard like the one on the screen, so you can enter your questions here. The presenters this evening are also happy if you want to raise your hand, and hopefully you can see the little box where you can do so. And if you want to ask a question that way, we're happy to unmute you so you can articulate your question over the webinar. If there are questions in the question box, the presenters may choose to address some of these during the session or address them at the end of the session. Just a quick note on your audio. If the sound's not coming through too clearly now, you may prefer to switch to the audio via your phone, and you'll see those numbers listed on your dashboard. So your presenters for this evening are Dr. Sarah Dunlop. She is a palliative care consultant in the Southwest region, and joining her this evening is Dr. Stephen Hinton, a Bunbury general physician. I will now pass you over to Sarah, who will start the presentation. If you can bear with us this evening, because all three of us are in separate locations, so there might just be a slight lag as we change screens. But you should have the controls now, Sarah.
Okay, it looks like it. I'll just double check that you can see my screen. You can. So yeah. I'll just switch back to that. So I won't labour the point too much with too many slides, because I know Stephen and I were both keen that we wanted the mainstay of today to be about your questions and discussion around goals of patient care, particularly in light of COVID-19. Rather than a whole load of bland slides that you'll probably forget about as soon as we finish the presentation. So I thought what I'd try and cover is a bit about what goals of care is, some of the communication skills and tips that you might find useful, and a brief bit about resources, symptom control and other useful resources that have been developed and pushed forward a bit around COVID-19. So goals of patient care really came out of addressing some of the limitations of do not attempt resuscitation orders. So you know that these are ubiquitous worldwide. It's usually a binary decision. Are we going to commence CPR in the event of a cardiac arrest or not? But it ignores the huge range of burdensome interventions that we can give to people now that may alter the trajectory of their illness, and trying to refocus some of that decision making onto the patient and contribute to what we consider patient-centered care, which is increasingly becoming a standard of care worldwide. So there's really two phases of the whole Goals of Care project. One is the conversation, and the second part is the documentation. Essentially what Kirsten Orett, who's now the palliative care lead for WACS, talks about is care now planning versus advanced care planning. So I think we're probably all familiar with the term advanced care planning, and that might take the form of an advanced health directive, advanced care plan, enduring power of attorney, enduring power of guardianship. But how care now is a bit different is we're not thinking about further down the future, the what ifs. It's we're faced at the moment with this COVID-19 situation. What are we going to do if you get this now? Generally speaking, Goals of Care has been focused and developed for the inpatient setting rather than the outpatient setting. So you may find that if you're using it in nursing homes and trying to utilize it, may not completely meet your needs in the same way that an advanced health directive might do. And the idea is that it's going to be the same form that's pushed out statewide in urban and rural areas, public and private hospitals. So the people at the Department of Health that are keen to roll this out don't want us adapting the form or changing it much. From my experience, Section 4 has tended to be the underutilised section, and this is going to be the part that's probably most relevant to doctors in the community. So Section 4, if we look at the form, talks about extended use. And so you can see the front page there on the left-hand side of your screen, the back page on the right. So initially you'd fill in the patient demographics, then you'd decide after a discussion with the patient and or the person responsible and family what level of care you're really talking about. And then there's a space for the discussion on the back part of the form. The extended use section means that ideally every patient coming in for each new episode of care, each new admission to hospital, should have a goals of patient care form filled in for that episode of care. The exception to that is if the extended use section is signed off by a consultant. It does say consultant's name, but that could be senior medical practitioner, GP, essentially the doctor that's in charge of the care at that time. And if that's signed off, the form can be extended use for up to 12 months or unless another date specified on the form. And there's room there to freehand why you've come to that decision. So the kind of situations that would be useful in if you've got a frequent flyer who comes in with exacerbations of COPD, for example, they've had multiple admissions with infective exacerbations that year, you may want to once have the conversation about active ward-based treatment perhaps, but not escalating to intubation ventilation. But you don't want to keep having to have that discussion every single episode of care. You can sign it off for the extended use in that scenario. So what we know already about advanced care planning is that most people are open to discussing advanced care planning, i.e. death and dying, and most people prefer that the doctor raises discussion rather than having to initiate it themselves. And again, most people prefer that that discussion is had with somebody that they already have an established relationship, i.e. their own GP, or if they're seeing a particular outpatient specialist regularly. In saying that, 70% roundabouts in studies are open to having that discussion, but that still leaves a significant percentage that aren't. And so I know from seeing the draft goals of care protocol that's been established for WACC, the idea is that we would have these goals of care discussions early on in a patient's admission to hospital within 48 hours, ideally. But you are going to find a selection of patients, at the front door of the hospital who aren't willing to go there, or that it's not totally relevant right at the beginning. But the idea is that with the evolving clinical situation, you review that goals of care and work out, is it still appropriate? So just because a goal of care might have been established at the front door in the emergency department doesn't necessarily stand that that will be reviewed throughout the course of the admission. So this is just another quick website if you're thinking about introducing this conversation, particularly in nursing homes, and starting to formalize your approach to advanced care planning in the COVID environment. This might be a useful website to indicate to your patients and more likely their families. So Dying to Talk is a website that usually gets trotted out around Palliative Care Week in May. And it's got this discussion starter kit there that people can fill in either online or complete it and print it out and retain it. But it's got a few useful hints and tips for how to think about, what's important to you, what would be your deal breakers in terms of interventions and treatments that you wouldn't want, as well as what you would want. So a few kind of hints and tips about the communication style. So ask, tell, ask is a really common communication style in palliative care. So it's sort of the opposite to what you see sometimes the medical registrars do in family meetings. They often go around, introduce everybody, introduce themselves, and then launch into this really long, really medically laden language discussion about exactly what's happened throughout the course of the admission, right up until the point that they're wanting to really do a discharge planning discussion. And you see all these baffled looking faces of family around. How I tend to approach the same thing is ask the patient to tell you what they know before you give them information. And that does two things. First of all, it establishes what they know. But second of all, it helps you pitch the level of conversation. Because it's going to be very different if you've got somebody who is an ex-nurse or doctor telling you what their understanding is versus somebody that's got poor health literacy and hasn't really understood anything right from the beginning. So you ask them their understanding of where they're at, then tell them the information, and then ask them more about it if they've got any other questions. Chunk and check goes along with that. And it's this idea that we can only retain small chunks of information at a time. So you should never give more than 3 items of new information at one point before going back and checking with them, do you understand that? And a useful test of that is to get them to repeat in their own words what you've just told them. Nurse is slightly different, and again, it's a tool that I use day to day in palliative care communication. But it's really for picking up on those emotional cues that oftentimes you'll find in conversations, you're sensing that there's an elephant in the room, that the person that you're speaking to either is disengaged or angry or frustrated. This is how to try and tease that out and what's going on there. So the first one is name it. So what I like to think of is, imagine you're an alien coming down from outer space. You've never seen this emotion before. What is that emotion that you're reading? And name it out loud to the patient. So it seems like you're angry, or it seems like you're frustrated. Understand the core message is really getting to the root of why that's the emotion that you're seeing. So are they really angry because you're 5 minutes late to your clinic appointment? Or are they really angry because they've just had a diagnosis of cancer? They've been sent to 3 different hospitals. Nobody really gives them a straight answer as to what's going on, and they're feeling confused and frightened about what might happen to them. Respect is a statement like, it's a real testament to you that you've managed to look after your mother for this long on your own. The support often goes along with that. If you're giving bad news, for example, this is difficult information. Would you like me to be there when you tell your family, or would you like me to tell the family for you? And explore tends to go quite well with name it, which is, it seems like you're angry. Can you tell me a bit more as to why? So it's not necessary to go through these tools in order. Some of them you might use, I use name it and explore a lot. But the other ones I find tend to come out in the consult a little bit if you start by naming that emotion out loud. I won't labour the point too much on these next couple of slides because I think Stephen's going to cover more of that. But there is good information that's been coming out in the COVID-19 setting about how to go about those conversations about goal setting with patients. And there's a Vital Talk US website that's linked into the Goals of Care in the COVID-19 environment website, the details of which I'll flash up later. But what that Vital Talk website talks about a lot is the wish word. We wish it were different. And that's actually, strangely enough, a validated word, because it conveys to people that you do care and you're recognizing the issue that they're raising. You want it to be different, but you can't. And so in studies, wish has been used as a very effective term. This website, podcast that I listened to from the US, there was a geriatrician talking about having focused goal-setting discussions for nursing home residents, and really saying that if they're focused, they can be done in 10 to 15 minutes. So the information he was recommending is conveyed is that COVID-19 can be fatal, especially for people in their 70s and 80s. The only thing that can be offered in hospital that's different to the nursing home is they can offer mechanical ventilation. And for some of our nursing homes, of course, it could also mean they have piped oxygen in the hospital that they don't have there. And studies show that for older people, once mechanical ventilation is required, people typically don't survive longer than 48 to 72 hours. So again, I won't go too much into this natural history of the disease, because I think that's going to be covered later. But these are the resources that I wanted to make sure that you had. So ANSPAM, you'll probably know, is the Australian New Zealand Society of Palliative Medicine. And as far as I know, these are free to air kind of open access PDF files that they've developed. One is a little bit about the context in which they've created these PDF files. Then they have a bit about symptom control, which is a really useful, just one-page A4 summary about the symptom control at end of life for COVID-19 patients. I would actually go further as to say that's just good standard advice for terminal phase prescribing, even outside of COVID-19. They've got a section on palliative care communication in the COVID-19 area, and they've got a bit around ethical decision making and access to medications and syringe drivers, etc. So that's an Australian-wide publication. The local one that's been developed in WA has been Goals of Care and End of Life in the COVID-19 Environment. So that's the link to that website. And that's, again, really useful in terms of it's got a few videos about what the Goals of Care document involves, some communication tips. And it's also got a series of videos on different aspects of symptom control run by Penny Tuffin, who's, I'm going to get her title wrong, but a very, very clever and experienced pharmacist in palliative care. So she's done a series of videos for the Cancer Council about prescribing and anticipating end-of-life care needs. And that last website there is the Dying to Talk website, which I think is a useful starting point to give to families when they're wanting to engage with you about these goal-setting discussions. So that's really all from me. I haven't seen any questions pop up, but I might hand over to Stephen then if there aren't any questions.
All right. Well, I'll carry on if there are no questions. I must say I did try to enter a question myself, Beth, and nothing would come up in the box. So I just wonder exactly how it needs to be done, but I was not successful myself.
Thank you, Stephen. If there's anybody else online who would like to attempt even just to throw a test question into the box, that would be good for us just to check that it's working. Oh, hang on a minute. There we go. I've just seen a question come through. Yep, a couple testing ones come through. So hopefully, Stephen and Sarah, you can both see those questions that are there.
I can just see testing.
Yeah,
Working.
test working, question mark. Yeah.
But I'm not sure how to enter it myself. I did try entering one, but when I typed into the box there, it entered no text. The question that I did want to ask you, Sarah, was just on that one that you mentioned on, I think, part 4, was it? That you said is an underutilized section. There was a note there for persons moving from one institution to another, that it was a consultant who needed to sign to say that these goals of care are transportable. What specifically do they mean by that? Because when a patient is in a nursing home care, their consultant is often their general practitioner.
Yeah.
What's the real meaning of that term consultant?
So in Busselton, I know a few of our attendees are from Busselton, they have the same form, and as you know there, the majority of the staff are senior medical practitioners, SMPs, so they may not be a consultant, but they're certainly a senior medical practitioner. The idea is really that the most senior person, the most senior clinician looking after the patient can agree that. So to be honest, I don't really see why an experienced nurse couldn't complete that. I think it's just part of the nomenclature of the form. There have been discussions, as far as I know, about changing it to clinician rather than consultant. But I know that the Department of Health are keen that we don't adapt the form. But essentially, if the GP or if an SMP or similar was prepared to sign off that form for the next 12 months and that seemed appropriate, you know, I don't think there would be any questions raised about that.
So the term is fairly general.
Yeah, I think it's probably more specific than it needs to be. I think it really should say clinician.
Yeah. Okay, that was my question. I don't know if there are any others that have come up for you.
That's actually covered in the draft policy that I was given yesterday as well. So that's their interpretation of that word consultant, is really it should read clinician.
Okay. Right, if there are not any other questions, then I'll go on. Were there any others that you saw that you need to answer, Sarah?
Let me see. It's very small. Test working. Can the family member involved in goal of care? So yeah, I think I get what you're asking. So yes, absolutely, family members can be involved in the goal setting conversation, and they should be. On the back of the form, you might have noticed in a previous slide that there's a section for with whom that discussion was had and points from the discussion. So I'd encourage you guys to fill that in if you can. I guess the point to be clear on, though, is that ultimately the decision whether to resuscitate or the decision whether to give a patient a treatment or not is actually resting with the doctor. So if you feel that a certain treatment is inappropriate, you do not have the responsibility to acquiesce to any request that a family member asks you to. It's for the same reason that we don't give vitamin C infusions to patients with cancer. It's not an established treatment that gives that derives benefit. So ultimately, the decision to offer a treatment depends on the patient and you as the doctor coming to that decision. Sometimes people have nominated an enduring power of guardianship. Sometimes there's a bit of misinformation out there as well, that the person that's nominated assumes, right, that's it, I've got carte blanche, I can make all the decisions for mum now. That's not the case. Enduring power of guardianship only comes into action if the patient loses the capacity for that decision making. So when they're conscious and competent, that discussion should always be had with the patient first. And if they're not conscious or competent to make that decision, that's when the nominated guardian is able to make that decision on their behalf. And usually what I tell the guardian is, this isn't really a decision about what you think. Really, your job here as the guardian is to be the mouthpiece for mum or dad when they couldn't speak for themselves. So if they could speak for themselves right now, what would they say they wanted? And that makes it an awful lot clearer for people. But regardless, even if somebody's a nominated guardian, even if they're a spouse or next of kin, they can't go over the patient unless that the patient lacks capacity. See if there are any more. Any VAD in COVID discussion? So this was a question that was raised beforehand, I think, as well. So, so you guys are probably aware that voluntary assisted dying, that bill was passed by the Upper House in December of last year. And though the bill has been passed, it's not actually a legal framework that's in place for that as yet. And the plan is it's going to follow more of the Victorian schema of 18 months of planning before voluntary assisted dying actually comes in. Regardless of the COVID situation, rather than bringing it forward, it's actually potentially going to push things back, because where we had 18 months to plan and work out how it's going to work practically, a lot of that time and energy and effort has been taken up with planning around COVID-19 now. So if anything, I think it's going to delay access to voluntary assisted dying rather than speed it up. And we certainly wouldn't be advocating that people see voluntary assisted dying as a treatment option for COVID. We'd be talking about intensive care management versus comfort-focused management. And I think it's important to say as well that when we're telling people that that they wouldn't be a suitable candidate for intubation and ventilation, that does not mean no care. And we shouldn't be saying to people, there's nothing more we can do, because there's always more we can do in terms of providing comfort. So nobody goes without care is sort of the wax tagline at the moment around COVID-19. Unfortunately, misleading wording for healthcare professionals. I think that's related to the consultants point. Yes, I'd agreed. Voluntary assisted dying comes up again. Do you see that nursing and allied health staff can assist doctors with goals of care planning and discussions? Absolutely, yes. I think that's really important. I was involved as my advanced training registrar research in implementing goals of patient care in Murdoch Hospital, which is another St John of God private hospital. There we piloted the paperwork on Thomas Furlong ward, which is primarily an oncology ward. So knowing that people with an advanced malignancy have a rate of successful resuscitation in the order of 1 to 2%, you'd imagine that the vast majority of patients had a goals of patient care form in their notes. The actual number was something like 14–15% actually had one completed. And I think one of the biggest challenges actually has been uptake of the form, and us as doctors recognizing those general indicators of decline and specific indicators of decline that point towards people's prognosis drawing shorter. And I think we as doctors aren't as good maybe at picking up on those fixed criteria as maybe nurses and other allied health professionals are at times. My thought around those figures is maybe in time we could have a sort of specialist nurse position where an experienced nurse who's good at having open conversations about advanced care planning could go with a set of fixed criteria to every patient admitted in that 48-hour period, work out who would benefit from a goal-setting conversation and help come alongside the treating doctors in initiating that conversation, because there are some of us that are better at it than others, and some of us need just a little bit of steering one way or another about it. So I certainly see a role for the rest of the medical team, not exclusively doctors in that. Though at the moment the expectation is that these are high-level discussions, they're nuanced medical discussions to be had. We're not recommending that junior doctors and interns have them in isolation. So it should all be agreed with the most senior member of the treating team. I'm just trying to look through any of these. It's not the easiest format for actually looking at the questions, I'm afraid. Tried CPR as patient. CPR should probably be limited, but at least we can tell the family we tried CPR as patient wanted this, but died despite this. Yeah, that's a tricky one. It comes down to this question, I think, of futility again. So we know that people with chronic health conditions, well, let's start with all comers. The rate of successful resuscitation for all comers in hospital is something in the order of 17%. Not very good odds at the outset. We know when people have life-limiting illness such as chronic kidney disease, liver failure, other organ dysfunctions, that rate drops down to somewhere between 6 and 8%. In advanced malignancy, 1 to 2%. And those of us that have done CPR on people know just how burdensome that treatment is. There's a lot of misinformation within the public that I think sometimes people assume that this is a treatment that's going to make you better once you have CPR. The reality is that the morbidity associated with CPR is pretty terrible as well. And while you might survive immediately a resus attempt, your 3-month prognosis, your 6-month, your year prognosis is very poor after you've had a resus, even if it was successful. So I really don't think we should be advocating for treatments that are likely to cause more harm than good. And I find when you explain to people, oftentimes people say, oh, well, she'd always said, you know, if I'm going to end up like a vegetable or I'm going to end up on a life support machine, then she wouldn't want to live like that. That's no quality of life and she wouldn't want that. I think when you explain to people that, well, look, there's unfortunately, if we go ahead with a resus, there's no guarantees that that wouldn't happen. And in fact, if you were expecting that your loved one might be able to go back to the level of independence that they enjoyed beforehand, the reality is that's pretty unlikely. And once you explain that to people, they're often more agreeable. The sort of caveat that comes to mind is I remember having a patient in the community with quite an advanced liver cancer, an HCC, and he was really quite strong in his argument that he really felt, feeling as he did right now, that he would be able to survive a resuscitation attempt if his heart were to stop, and that he felt that was a treatment that he deserved to have. But when we teased it out a little bit further, what we ended up agreeing on was, look, feeling as you are right now, if you walked out of the house on your mile-long walk that you do every day, and you got hit by a bus in the street, and you had a cardiac arrest as a consequence of that, you would want to be resuscitated from that, by the sounds of it. But if your disease was progressing, you were becoming more symptomatic, and it was clear that this was because your cancer was getting worse and we had no other treatment options. If your heart were to stop in that context, we wouldn't resuscitate you. Is that fair? And that's what we ended up agreeing on. And the much more likely option, of course, with his advanced liver cancer was that it was going to be option 2 rather than option 1. But that could have been a bone of contention, and we came to some sort of resolution about that. I'm a bit mindful of the time. I want to allow Stephen some time to speak as well, so I might just leave it there, but apologies if I've missed any questions in that.
No, thanks for that, Sarah. I've prepared a short presentation on COVID-19 with notes regarding the general clinical presentation, and in particular the problems with high-risk groups. Sarah, can you mute? I seem to be getting some feedback. Thanks. The clinical presentations that we're likely to see of patients coming through with COVID-19, we expect to be highly varied. I say expect because although we were expecting by this stage to be quite experienced in the management of COVID, we've been very fortunate in having very few cases. So most of the information has been gained from other countries that have had a much greater experience, much worse experience than we've had. But if you look at the presentations, as you know, most of us, when entering the hospital, are being checked to see whether we've got a fever. It's a very inefficient way of actually determining that a person is carrying COVID, because even amongst the cases that present as clinically presenting COVID patients, 44 to 94% of them may have a fever. And there are many reasons for that, as some of them are listed there: age, the recent use of antipyretics, and so on. Cough is quite a reliable sign in those who have got pneumonia. So those who are presenting already with a pneumonia are highly likely to cough. Loss of smell and or disturbance of taste seems to be a particularly common symptom in people who have mild COVID infection. Upper respiratory symptoms were initially thought to be a rule out for COVID, that COVID was a pneumonic condition and upper respiratory symptoms were more in favor of rhinoviruses, adenoviruses, influenza, and others. But in fact, COVID quite often does produce upper respiratory symptoms, not just lower respiratory symptoms. Dyspnea, well, that's very dependent on the degree of pulmonary involvement. Fatigue's quite prominent, myalgias, headaches, confusion, and gastrointestinal symptoms are all ways that it can present. But there are also many patients who've had COVID infection who have been unaware that they've actually already had the virus and may have already developed immunity to it, and they have had a completely asymptomatic course throughout their COVID infection. And we don't even know what size that group may be. I think it's going to depend on us getting a lot more testing done and the passage of a lot more time before we actually find out just how many people are having completely silent COVID infection. But it is happening. Just some important markers on those who do get severe COVID infection. How does this disease progress? Well, generally the duration of the fever is from 4 days to about 2 weeks. The duration of time that they're dyspneic is about 2 weeks, and the cough goes on for about 3 weeks. When you look at those who die, the median onset of illness to death is 18 days. If they survive, the onset of illness to discharge about 3 weeks. And hospitalization has been pretty close to a fortnight in hospital on average. If you look at the timing of complications that they develop, generally sepsis day 9, ARDS day 12, mechanical ventilation also around about between those days at about the 10th day. Longer survivors are prone to develop cardiac and kidney injury, and the longer you stay in hospital, as you'd expect, the higher your risk of developing a secondary infection. So those are the sort of ballpark figures that we're starting to see, with the ranges that that you also see in brackets behind that. If you look at how people are dying, respiratory failure alone, about half, mixed respiratory and circulatory failure, about a third. Circulatory failure alone is a small proportion, as is the uncertain or unknown group. So that's the way that they die. You can see respiratory failure stands out there as a significant threat. If you look at the risk factors for dying, if you look at the fatality ratio by age in China, and this data has been borne out in other sites as well, this graph shows quite clearly the danger that age poses to your risk of fatality if you do get severe COVID. So it was data like this that led us to be quite concerned about the prospect of our hospitals firstly being overwhelmed by a surge in presentations of patients with COVID, but also the likelihood that our resources would not be sufficient and there would be a number of choices to be made in terms of who gets to use the resources and gets to be actively treated as having the best chance of surviving. And there appeared to be a high risk that we would have a lot of people who would not be able to be supported adequately, and that if data such as this was being used to determine who has the best prognosis, that our nursing home residents may actually receive better care by not coming to hospital, or at least equivalent care by not coming to hospital. And if they were going to choose to stay outside of hospitals that were overwhelmed, how could we support those people who would be looking after them in the nursing homes where they remained? And it was at that stage that this meeting, I think, was thought about, and we were looking at ways to support the provision of medical care for older folk who stayed in nursing homes, who decided they would prefer not to come to hospital. So we've been quite fortunate in that scenario has not eventuated. We have not got to that situation. It may still come, but yeah, it hasn't yet. So besides the fact that age is an indicator of risk of mortality, what are the other comorbidities? Well, if you look at the additional data that we have on medical conditions, you can see that hypertension was twice as prevalent in non-survivors, diabetes twice as common, coronary heart disease 24 times higher. So there are certain comorbidities that were additional markers of increased risk of dying if you contracted COVID. And hypertension is not usually associated with major risk of death from an infection. So that's quite unusual to find that a condition as benign as hypertension was doubling the mortality. And we still don't know exactly why that is, that simply being hypertensive creates such a high risk, given that the disease is mainly killing people through a respiratory disease. But anyway, it is data that's important in determining what an admitted patient's prognosis looks like. So those are you know, some of the outlines of what symptoms they present with, how rapidly it progresses, what the timelines for various complications might look like. There's a lot of data out there, and I didn't want to go through exhaustively through all of the COVID literature. I'm sure you've been reading a fair amount yourself and may have even been swamped by too much information. But I thought that we'd perhaps look a little bit more closely at the experience people have had in nursing homes. And there were 2 studies published from King County, Washington, that looked at outbreaks in nursing homes that quite informative, really. The first information that we got was that, you know, there was a nursing home with a number of patients that became infected after a member of staff brought the infection into the institution. And if you look at the progression of the outbreak within that institution, you can see how many residents became infected and how the numbers rapidly grew. The number of infected cases then declines, mainly because the population that are susceptible is, you know, has passed the infection now. But if you look at the doubling time of cases, it was about 3.5 days. So once an infection does get into an environment like a nursing home, it really moves very swiftly through the residents and also through healthcare personnel. So that gave us a good idea on, okay, what happens in a closed environment like that? And if you look at the characteristics, there's a long table here, but I just wanted to have a look at, let's just see, where is it? It's not coming up there, but I just wanted to highlight this here, the death rate. amongst the residents, so in the group of 100 residents, the mortality rate is 1/3. So, okay, that gives us a good idea. If it gets into a nursing home, it'll double every 3.5 days, unless you take particular precautions to prevent that happening. And you can expect that about 1/3 of your residents are likely to die in a nursing home. So that's not 100%. It doesn't mean, you know, COVID gets into a nursing home and everyone over 70 dies. It's about 1/3. So that's still a significant number. It's useful information to have, to know what other people's experience has been. There was some other additional information that was gained. I think it is the same company that runs these nursing homes in that area. And in another study, they looked at infected patients to see just how much infection was going through. So they actively sought cases. They tested everybody. And they found a 64% prevalence of COVID amongst residents, with a case fatality rate, again, of close to 1/3, 26%. And that occurred despite the early adoption of control measures. And COVID was diagnosed in 20% of staff. The interesting thing, the bottom line there, more than half of the residents with a positive test for COVID were asymptomatic. So that even in this elderly population group, a large number of them were becoming infected and were asymptomatic. They didn't have evidence of clinical illness, didn't complain of it, and the staff weren't actually aware of it until they were actually tested for COVID. So there's still, you know, there's a significant submerged iceberg, even in nursing homes. So there's a fear then that the transmission from asymptomatic residents likely contributed to the rapid and extensive spread to other staff, that it's not just the people with a temperature of 38 and above who are coughing and short of breath and can't taste their food that are, you know, people that are clearly infected and at risk of transmitting it to staff. There's a significant number of people there that'll be infected and not obviously unwell. So if you do base your management strategy just on symptoms, you're going to miss an opportunity to prevent spread, which was interesting. So it does look like, you know, if you get an outbreak in an institution like a nursing home, that there should be quite strict use of personal protective equipment on all people in there, even those who don't appear to be unwell. So that's a little bit of the initial presentation, how patients present, how they progress, what has been seen when there have been outbreaks in nursing homes. And just the other side is those who are acutely unwell and become respiratory failure patients that need mechanical respiratory support. Looking at the guidelines from the Australian New Zealand Intensive Care Society, they recommend reserving ICU admission for patients requiring ICU specific interventions. And this is not a sort of general blanket rule. This is COVID specific guidelines that the Australian New Zealand Intensive Care Society have put out, and this is the second revision. So they recommend that patients who only require monitoring be managed in an alternative location, and ICU admissions should be prioritized to those who require specific interventions, particularly ventilation. So we were looking at how do we manage the surge, if the surge eventuated, in a situation where ICU will be managing those requiring mechanical ventilation, and the wards would be expected to manage all those who don't qualify, or everyone else once all of the ICU ventilated beds are occupied. and that posed a bit of a problem. So the Australia-New Zealand Intensive Care Society also recommended that the non-ICU components of hospitals, and that would include nursing homes, are involved in some sort of rapid response and medical emergency team development. So, yep, okay, so that's appropriate for hospital, that the medical emergency response team no longer depends on the participation of someone from ICU, that it would be, say, medical registrar and ED registrar run, and that involves some reconfiguration. But the other thing that they recommended is that please, at the front door, establish goals of care on any admitted patients. And we hope that you in the community will be involved in developing goals of care even before they do arrive at hospital. But those who do arrive at hospital, we attempt to establish at admission what their expectations are, what their wishes are, what their concerns are in terms of treatment they would regard as not quite what they were hoping for. So those are early conversations now for patients coming into hospital with acute respiratory failure. And the goals of care now are documented twice. The first documentation now is an electronic document on the BOSNet system, and a second is that document where the goals of care have been determined is printed, and a copy of that is put in the patient's file that is located at the bedside, so that if a MET team arrives, they don't need a computer to access the goals of care form. Now, this is taken from the front page of the Australian today. Waiting for death, residents fear they'll be next. There are a lot of nursing home residents who are very anxious, and I think their relatives are too. And there's some significant concern that being elderly and being in a nursing home may automatically disqualify you from care that you feel you may deserve. So I just want to make it clear that there's no point in being completely negative about the outcome in anyone who's elderly. While the mortality rate is high, there are a lot of older folk with comorbidities that are surviving this virus and may want to be treated, and the hospitals are not excluding them from receiving appropriate care if that is their wish, and if those resources are available. So, you know, the contingency plans that we've been considering have been based on the expectation that we'll have a surge that may overwhelm our resources and our ability. We actually we've not had that as our experience. We've been very, very fortunate. So the availability of resources are still such that we could offer hospital care to those who want it, and that's something I just want to highlight. It's not a case of you know, waiting for death. You may get sick, but you don't necessarily die. There's been a lot of literature as well about the ethical values that may be used to help when there is a situation of rationing of resources. I think there are a lot of sore heads from doing a lot of thinking about these ethical decisions, and we've seen in Italy particularly, but I think also in Spain and also in New York, parts of the US, and there was also some situations in Washington where resources were limited and really painful decisions had to be made. So there's a few guidelines out there on how you approach this. But there's not universal consensus on all of these guidelines and the best way to implement them and so on. But there is concern that decisions will have to be made about who gets ventilated, and we're looking at things like severity scores, the sequential organ failure assessment score. That's a good pointer to who's too sick to be ventilated, and you get better results if you ventilate someone whose score's not too high. Decision making when it comes to limited resources and rationing, there's been a decision to have a committee, certainly in Bunbury Hospital, and that's not a formal committee, but an informal agreement that if that situation is reached, that there will be a small panel that would be independent of that patient's management team and analyze the raw data and attempt to categorize patients in terms of those most likely to benefit, least likely to benefit, to help with the rationing of services, if we get to that stage. But as I say, we are a long way from that position. And there's also been some discussion about, okay, how do you withdraw ventilation once if you've made a decision to do that, and you now decide you have reached a point of futility? How do you withdraw ventilation atraumatically? That's going to also require team support. So some of the published articles with thoughts on how we approach the ethical decision and so on have generated a few reactions, and this is just a few of the reactions. That, people are worried that people are failing to discuss bias, discrimination, disability, that they're glaring omissions there, that removing patients from ICU beds and ventilators to give resources to other patients is actually unlawful, and it is. It's not something that anyone's advocating, but it's been a point that has been discussed, but it is actually unlawful. And there are problems with ethical analysis and the contextual influences, the importance of relational effects, and the flawed assumption that there's consensus among clinicians about prognostic indicators. The same patient's prognosis, when assessed by different clinicians from the same craft group, may vary, but you can be quite sure that clinicians from different craft groups may come up with very different predicted prognostic scores for patients. And we know that general societal trust of any central decision-making process is, their trust is pretty low at the moment. So we need to be aware of all of these factors when deciding how we manage the situation if it gets to a crisis and rationing situation. But luckily, that's not the position that we have found ourselves in. It was certainly feared that that would be the case just a month ago, and we've been quite fortunate. We are likely to see, as the restrictions are relaxed, we are likely to see a increase in the number of cases, and if we can keep the number of cases in the community and the turnover of infections relatively low and controllable, then we could probably let the infection run its course in the community without overwhelming the resources that we have in the community. Hopefully that's the way it will happen, but we're still concerned to make sure that those who stay outside of the hospital system remain supported. And the aim of this meeting this evening was to find out in what way we in the hospital, as clinicians and palliative care specialists, could help community-based practitioners better. So that's what I wanted to cover. If there's any questions, I'll take questions as well. If there's specific issues that you feel we need to be made aware of and need to help you with, then we're listening.
Stephen, one of the, I've tried to delete any of those questions that I think we'd already covered, but one that I haven't completely covered and I'd be interested to get your point of view on is this one. Please can you explain what to put on a goals of care form when a patient wants CPR, but medical opinion is inappropriate? What medical director advised is to put goal of care as per patient request, but do good handover, really likely futility, so CPR probably should be limited, but at least we can then tell the family that we tried, as this is CPR is what the patient wanted and they died despite this. So I guess the question is, what if you're at odds with the patient or the family? What if, despite them really wanting resuscitation, you feel medically it's inappropriate? How would you suggest documenting that?
Well, the decision to use CPR as a life-prolonging rescue intervention does rest with the clinician. So the wishes of the patient are not the final decision on whether CPR is used. If a patient does collapse and you know that their resuscitation ability is close to 0 or 0, then it's actually unethical to use a form of therapy you know to be ineffective, and you shouldn't be using it if it is ineffective therapy, and it's likely to produce only more damage and use up resources that are futile in their expenditure. So you still have that responsibility to be using resources wisely. So if a patient wants CPR, says they want CPR, and you know that CPR won't work, well, you know that the rate of success for CPR in patients who arrest in a hospital because of pneumonia, even in highly resourced environments, is 0. You know, if you've got pneumonia and you have a cardiac arrest, you will not survive resuscitation. It's an intervention that was devised really for resuscitation of arrhythmia in arrhythmic death in otherwise reasonably functioning hearts. That's what it was devised for. It wasn't devised for pneumonia. It wasn't devised for strokes. It wasn't devised for people with, you know, advanced malignancies. So under those circumstances, yes, CPR and cardioversion works very well for a cardiac arrest, but under infections and malignancies, its success rate is very poor. So if there's a patient of mine who has a wish to have CPR, and I know that they will not benefit from it, I like to have a discussion up front on the lack of benefit that they would derive from CPR, and the reasons for my decision not to recommend them for CPR. but I I wouldn't leave them in the dark thinking that. I think that's a bit deceptive to let them think they'll get CPR and then have a go and have a half-hearted attempt, and that way they think that something has been done. I think it's best to be quite frank that the CPR will not work and should not be used, and get agreement on what's really going to happen. That's not an easy conversation to have.
Agreed. Thank you. It's useful to get your point of view on it as well. I know that one of the things I'd intended to say today as well is one of my mentors, Derek Eng, who's like the communication guru for palliative care in Perth. He's quite strong on not putting options on the table that aren't real options. So I think part of it is how you address the issue up front, is maybe not as a question that you're expecting people to decide their treatment options, but you say, here are the treatment options relevant to you. And if CPR isn't one of those options, don't present it as such. In the same sort of way that we don't offer PEG tubes for elderly demented patients who stop eating and drinking, because that's part of the natural history of a diagnosis with dementia. It's a progressive neurological illness. We know that it doesn't improve morbidity or mortality putting in a PEG tube in such patients, so it's generally not a treatment that's offered. In the same sort of way, if we know that it's going to be a futile procedure, and that's interesting, I didn't know that about cardiac arrest in the context of pneumonia, has a 0% chance of restarting somebody's heart. But if it's not a legitimate treatment, it's not something that we would offer. So I would often present it as, in your situation with what we know about your illness, we know that CPR isn't going to be a beneficial treatment to you, and everybody in their process of dying, at some point their heart stops. So we wouldn't want to put you through trying to restart your heart if that's the natural course of death for somebody in your situation. And most people, when you present it to them like that, I think are generally pretty pragmatic, and I have the sense that rural people are even more pragmatic than some of the city dwellers, and usually they're pretty happy to take the consultant's lead on it, the medical professional's lead on it. I think I'm definitely in favour of patient-centred care, but I also feel a little bit like it's somewhat eroded the role of the medical professional, and that we have a responsibility to help lead our patients towards our recommendation. And the other mentor that I had in that Royal Perth job was Kevin Ewan, and I've stolen one of his analogies, which is to say being in hospital is a lot like being in a restaurant. You've got a menu of options. You might ask us for a recommendation, but at the end of the day, the choice is yours. And so when you're giving those options and recommendations, you've got to make sure that they're legitimate options. There's a couple more questions here. I'll maybe read out to you, Stephen, because it took me a little while to unlock the question box. Pat Mulhern says, it's now 2 months since all patients in VO Italy were tested. 3% were positive, but 70% were asymptomatic. But how many of those stayed asymptomatic?
Yeah, good question, and one I can't accurately answer. I don't know the exact percentage, but not all. So some of those who tested negative when retested were positive, and some of those who tested negative and were asymptomatic went on to develop symptomatic disease, but not a lot. So we don't know the data fully. The requirement for more data is there, and the only way we're going to learn more is if there's more testing, and we've got a larger database. So our database at the moment is very skewed towards severe disease. We know about severe disease, we see severe disease, and we think that's COVID-19. But the more testing we do in the community, for those who are asymptomatic, the more we're going to find out that actually there's a large amount of people with disease that's a lot less severe, and asymptomatic, a large asymptomatic pool. So I think that the answer is, yeah, keep reading. We'll get the data eventually. I see there's another one there on cancer, patients and COVID. Is there any data? There is. The data is, again, quite limited. The early data from China did not include a lot of patients with cancer, so we didn't see exactly how much risk is posed by a cancer diagnosis, number one, nor by how much risk comes from cancer chemotherapy. So that information is still very limited, but there is data from other countries that indicate cancer is a significant risk factor, but it doesn't seem to be as bad as cardiovascular risk factors like hypertension and heart failure and diabetes. So that may change, though, as our experience, as we gain more experience with it. Right. No, that was all there was with questions. Yep, and then there is a thank you note. Yeah, well, it's a pleasure. Thanks. Thanks for attending. And if there is anything that you think that we can do that would be supportive to your practices and your ability to care for patients in the community, you know, let us know what specific requirements you have.
Thank you, everybody, for joining us this evening. Thank you to Stephen and Sarah for your time for a very informative session. Letting everybody know that we have recorded this evening's webinar, so we can make sure that we can send that out to all the participants that were online this evening. So we will close the webinar now. So enjoy your evening, everybody. Thank you.